Good afternoon. Thank you for joining us. We're about to move into our afternoon sessions. We have 3 panels in store for you. There is not a scheduled break in the afternoon, but feel free to take any bio breaks you need on your own, and I consider you should go on demand. I'm going to turn it over now to our Director of the Office of Minority Health. She will be presenting along with her colleague, Jean Moody-Williams, and they will be discussing Quality, the Equalizer.
So thank you, Pamela, and good afternoon to all of you and those of you who may have joined us. As Pamela mentioned, we're going to talk today about Quality, the Equalizer, and I'm thrilled to be joined by Jean Moody-Williams, who is our Deputy Director in the Center for Clinical Standards and Quality here at CMS. And in this capacity, she leads policy activities for our quality improvement organizations, end-stage renal disease networks, survey and certification, quality measurement and health assessment, clinical standards, coverage analysis. I could go on and on. In short, she's incredibly busy. But the work that CCSQ does and under Jean's leadership and working with the one of our key partners in the agency is we're working to achieve health equity. So Jean is going to talk about the national and CMS quality strategies, and then we'll talk about some of our priorities as we're transitioning this afternoon from our understanding and awareness this morning into our developing and disseminating solutions and taking action. So Jean?
Thank you, Kara, and thanks to everyone in the audience for coming back after lunch. And as people continue to drift in, I'd like to spend just a few minutes talking about something that came out of the Affordable Care Act, in which there's not as much discussion about. Of course, most of the discussion is around the very important act of providing coverage so that millions of Americans can receive the health care that's needed in the country. However, there were a number of other provisions in the Affordable Care Act that our center has been very busy bringing about. One of which was in 3011, Section 3011, the National Quality Strategy. And this required that the Secretary of Health and Human Services develop a national strategy that would first align the activities of the federal components of the federal agencies within HHS, so that CMS and CDC and the Agency for Healthcare Research and Quality and the Office of the National Coordinator, you know, we were all going about doing goodwill and doing good quality and coming up with our initiatives. However, it was recognized that if we would align those efforts and work together, we could accomplish much more. And the provider community, the patients and the families would benefit as a result of that, because there would be at one time, as we would implement a quality program, we would have a set of measures, and maybe another center would have another set of measures, and we would expect that the provider community could follow all of these various mandates. One example, I think we had over 60 different ways of measuring hypertension. And through our alignment, through many of our quality activities, there are probably around 6 measures that are primarily used now in programs. So that's just one example. One of the other things that came out of this national quality strategy was the requirement that there be public input into the strategy. And so that the Secretary took great effort to seek input from states, counties, private payers, advocacy groups to develop the strategy. The next thing that came was that each agency had to develop an agency-specific plan. And with that, CMS began to develop the CMS quality strategy. The CMS quality strategy is very much in alignment with the national strategy, and the real purpose is to make sure that we fulfill the goals of that national strategy. But we took it very seriously here and worked over the course of a couple of years to develop our quality strategy. And within that, we worked to ensure that every component within CMS had some input into the strategy, but also we reached out to many of our partners that I see right in this audience today who helped to develop this and help us to get where we are today. So within our CMS quality strategy, you'll see that there are 3 aims: better care, healthier people, smarter spending, and there are 6 goals. And if you're familiar with the national strategy, you'll know that these came from that strategy. We want to make sure that care is safe, that we make sure to include and strengthen person and family-centered care. We want to have effective communication and coordination of care across various settings, promote effective prevention and treatment, best practices for healthy living. And this is something for CMS. You know, we have traditionally been one that paid claims. We are a payer, and a number of other areas that looking for fraud and abuse, but now we're all of a sudden in the business of population management, healthy living, promoting care practices. And this has been a great journey for all of us here. Still in an area where we have gaps in measurements and we'll continue to work on, but it makes sense when you think of we want to purchase value. And we also want to make sure that care is affordable. Now, another area that we included in the CMS quality strategy were these foundational principles. And these principles are essential into ensuring that we have a strategy that works. And we tried to put these principles under a goal. So let's see, we want to talk about fostering learning organizations. Which goal does that go under? Well, it crosses all of them. And the same was for eliminating disparities. We wanted to ensure that as we think about making care safe, as we think about coordination of care across settings, and all of the other goals, that we include the elimination, not reduction, the elimination of disparities. And so that it became a foundational principle. As we worked to see, so how are we going to make this a reality? We did not want to create a quality strategy. Many times, I know all of you have done strategic planning, and sometimes those strategies are developed and you come up with good goals and then they go on a shelf, and then, you know, maybe it's a 5-year plan, so about the 4th year you pull it off the shelf and then you start working on it again for the next 5 years. We wanted to make sure that didn't happen. So how do you make this a living, breathing document? And I think we were able to do that. Number one, our resources are driven, how we spend our resources are driven by the strategies. When we develop a scope of work as it relates to quality, if you open it up, probably you only need to go 3 or 4 pages in, you're going to find these goals. If you look at the measures that we use, for example, for our physician quality reporting system, for our hospital inpatient quality reporting programs, any of those value-based purchasing reporting programs, you're going to find these domains in the strategy. The other thing that we did was define affinity groups across the agency that could come together to talk about different areas such as population health, so that everyone in CMS who knows anything about or has an interest in population health, they have a place where they can go and brainstorm and problem solve. And that's one of the ways that we're making the strategy a reality. As far as elimination of racial and ethnic disparities, we came up with some themes that we wanted to incorporate in all of the goals. And this was our general effort to begin to have the discussion. These general topics formed the framework, which Kara is going to talk about in just a moment, for the Health Equity Plan. They were then able to take these and put more specificity or put some meat on the bones around all of these areas, looking at such things as stratified reporting, learning systems of care, making sure that we promote and look at culturally appropriate services, coordinating with existing initiatives. This is very important, that we not just go out and start doing things without looking to see what's already being done and how can we support those efforts to make sure that they are successful in partnership. So just a couple of examples I want to conclude with. When we think of such things as making care safer, the Office of the Inspector General came out with a report maybe about 4 years now that said that for, let's take a hospital setting, that 1 in 7 people that go into a hospital, 1 in 7 will suffer some type of harm. So if I had you count off in this room right now, you could see how many people might suffer harm. And usually when I say that in the room, people start pointing at somebody else. Well, it could be you, it could be me, it could be one of our family members. And so we really work to see how could we begin to move to make the healthcare experience safer. One area is adverse drug events. You know, how many of us have or have a relative or know someone, if you ask them, what medications are you taking, they'll bring you a big brown bag of medications. And we've seen this, we've talked to patients and went out into the homes and one of our programs, and they dump the bag of medications on the table. And in there, you're probably going to find some that are expired, some that are contraindicated with some of the other medications, some that may be the same, a brand or generic. And so we began an initiative where we worked with 57,000 Medicare beneficiaries, small number, but when you think of all the beneficiaries. Out of that 57,000, we found 44,000 instances of potential drug events that could occur if we weren't going through those medications. So this is really an area. Patrick Conway already talked a lot about the Partnership for Patients with 50,000 lives saved. We work for healthier communities. One of our quality improvement organizations, and I see some of our organizations here in the room, Texas is working with the diabetes program. Everyone with diabetes counts. Patrick talked about this today. We started this back in 2010. We enrolled 11,000 enrollees at that time, Hispanic and Native American populations. And since that time, 2015 to present, we're working nationally all across the country, enrolling. This is primarily focused on African Americans, Latino, Hispanic, Native American populations. And this is where we go straight to the beneficiary. We provide training, classes, they graduate from the classes. These are a couple comments from a few of our graduates. I think the best quote is, I feel happier. I feel happier every day because, and then you fill in the blank. Healthcare is so important to ensuring the quality of life. Results here, just for one example of a result, where we had in one of our projects, 35% of the population were out of control as far as diabetes, and we were able to reduce that to 15%. Still not good enough, but much better than it was. Lastly, making care affordable. We know that the workforce must be prepared for the changes that are taking place, where we're moving away from fee-for-service to all of these alternative payment arrangements, integrated care arrangements and contracts. How do we ensure that those that take care of the most vulnerable of the population are brought along and not left behind? One of the methods is through the Transforming Clinical Practice Initiative. We're investing overall over $700 million in moving along over 150,000 clinicians to make sure that they have the support and the technical assistance that they need to be able to practice in a system that is rapidly changing. But one of the requirements that we had for funding was that at least 20% of the clinicians that a group would come in with to ask for funding had to serve practices that were small in size, located in rural areas, or served the medically underserved. Macro, many of you are familiar with the Medicare Access and CHIP reauthorization, requires that there are a new merit-based incentive program, and we're wrapping up many of our value-based purchasing programs into one. And it provided for technical assistance for those professionals that are small in number, again, working in rural areas, health professional shortage areas, serving the underserved. And so we will be rolling this project out within the next several months, working with the Office of the National Coordinator. But with all of that said, you know, I've been working here at CMS now for 10 years, and I've seen great progress. And this conference today and Kara's work and the work of her office speaks to the progress that's being made. There's still a long way to go. And this is where we can all make a difference by all working together. together. Far too often, those who serve minority populations don't have the time, the resources, the organization to be able to contribute to the policy discussions. And then there are others that then speak for them. And then when the policy comes out, they will find that it doesn't meet what they need as far as supporting the payment structure, or the learning resources are not available, or it doesn't apply to the population that they're attended to. And this is where I think we have a weak link. And we all need to work together to make sure all voices are heard in the policy discussion. We're starting to do much better getting patient and family voices involved. I think we still have a ways to go in the areas of making sure that all of our vulnerable populations are heard. So your ideas, here's my email address. It's welcomed. But Kara is going to talk about how we can, one way in which we can get to that better state.
Thank you, Jean. So, let's see if you pop up with these. And I think, as Jean was just saying, the overarching message of this as we move forward today is we still have a lot of work to do, and we need all of you to help us in order to achieve our goal of health equity. So I wanted to take a few minutes to talk a little bit in terms of some of the things that our office has been doing as we've been building and working, and to talk specifically about what we're looking to do in the next few years as it relates to improving Medicare quality. I just want to again remind you about the offices, and we have some of our colleagues here. I see Dr. Junka Bull, who's the director of the FDA Office of Minority Health, and earlier we had Dr. Carol Jimenez, who's with the HHS Office of Minority Health. And these are partners that we work with, but also resources for you as you're looking into the work of the specific agencies to have a voice and a point of contact for achieving equity within there. Within the CMS Office of Minority Health, you can see that our mission really is to ensure that the voices and the needs of the populations we represent are present as the agency is developing, implementing, and evaluating its programs and policies. And you can see, as you've already guessed from the earlier presentations that we had this morning on the panels, that the populations we focus on are racial and ethnic minorities, sexual and gender minorities, and people with disabilities. And as you can see, we're working towards a situation in which all CMS beneficiaries have achieved their highest level of health, and disparities in healthcare quality and access have been eliminated. We've showed this earlier this morning, our equity framework of understanding and awareness of disparities, developing and disseminating solutions, and implementing sustainable actions so that we can achieve health equity. So what have we been doing? One of the things, and Dr. Chen already mentioned this, and we've heard it from a number of our panels, data, 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 data. As one of our CMS bureaucrats, Dr. Chris Hafer, says, if you can't measure it, you can't improve it. So we've been focusing on strengthening our CMS data and systems, and in particular improving CMS data on race and ethnicity and other demographics. We've added questions and working on cognitively testing questions for sexual and gender minorities on our Medicare current beneficiary survey. We are working on doing an oversample for our Hispanic population as well as Asian Americans, Native Hawaiians, and other Pacific Islanders, so we can do more detailed dives and understanding what's happening within these populations in Medicare. We've also been looking at some of our claims data to identify individuals who are transgender to begin understanding some of what the challenges are that these populations face. And we're working to develop and improve measures of the provision of culturally linguistically appropriate services with an eye towards how do we embed these in some of our quality improvement programs. You heard earlier about building the business case, and this is something we've been working on in terms of building the business case for health equity, and are implementing a number of efforts with regards to that to move that progress forward. And also in terms of developing and disseminating data products, this spring we released our first monthly data snapshots in which we're providing just snippets of data to help people understand some of the disparities that we see within our populations. We have quarterly data briefs, and so one of the ones that we've released is on looking at readmissions. But as well as we've been strengthening our data, we've been able, through the Medicare Health Outcomes Survey, to add the expanded race ethnicity categories from Section 4302 of the Affordable Care Act, and now are able to do detailed analysis within the Asian community, as well as the Native Hawaiian and other Pacific Islander, to understand health outcomes and quality of life for this population. We also now have a training module available through ResDAC for those disparities researchers who are interested in using CMS data to understand what's going on there, and encourage you all to use that and to share that. We also have been working on an initiative called From Coverage to Care, or as we like to call it, the So You Got Health Coverage, Now What project. And as we know, millions of people have come into the healthcare system. For some of them, this is the first time or the first time in a long time that they've had health coverage. And they may not understand some of the insurance terms or understand how to find a primary care provider to get the primary care and preventive services that they need. So we developed a number of resources, many of which are available outside on our table. And then we come today to our CMS equity plan for improving quality in Medicare. And one of the reasons that we did this is because, as we've seen, there's been much progress that's been made in terms of the overall quality of health for all populations. But each year, the Agency for Healthcare Research and Quality produces the National Healthcare Disparities Report that shows us that when we look at disparities in quality of care, overall, those gaps are remaining the same. And so we wanted to take an intentional effort and look at how do we try and shrink some of those gaps that we're seeing and move the needle so we have more bars in the yellow, more of the bar in the yellow reporting those that are improving. And this builds on the CMS quality strategy, which Jean has talked about already. So in developing this plan, we went through a year process, looking through the literature so that we weren't just pulling together activities, but seeing what was already out there, what had been successful that we could build upon. But we also talked to experts in racial and ethnic disparities, disparities for sexual and gender minorities, as well as people with disabilities, as well as experts in our CMS programs, because at the end of the day, we wanted to develop a plan that could work within CMS and be leveraging our opportunities to improve health equity. At the end of the day, we're here with 6 priority areas, which will be our focus areas for the next 4 years as we work to drive equity and achieve equity in our Medicare populations. But again, it's a building effort. It's going to be, as we evaluate and move forward, we will be doing continuous improvement and adding additional activities. But the 6 priorities cover all of our areas, as we talked about, of the understanding and awareness, developing and disseminating solutions, and taking action. Priority 1, no surprise, expand the collection and analysis of standardized data. We're looking at not just for race and ethnicity, primary language, sexual orientation, gender identity, and disability status. There are more detailed activities within each of these priorities, which you can find available on our website today. Our second priority builds and aligns with the HHS Disparities Action Plan, and it's to evaluate disparities impacts and integrate equity solutions across our CMS programs. The implementation and expansion of disparities impact statements was something that was part of the HHS Action Plan, and it's something we're looking to incorporate more as we look to not only understand the impacts of our programs on health equities as we're building them out, but also how we can build equity into the programs at the beginning. In our third priority, we're looking to develop and disseminate promising approaches to reduce health disparities. This is the taking action aspect of it. Where we can see, looking particularly at one of the areas of priority focus, as Jean mentioned, with Partnership for Patients, focusing on readmissions. But also we know there are a number of disparities that have occurred in nursing homes and looking at how we can improve nursing home care for vulnerable populations. Priority 4 focuses on our workforce and trying to increase the ability of our healthcare workforce to meet the needs of vulnerable populations through the promotion of our culturally linguistically appropriate standards, incorporating those, as well as working to build the business case for community health workers and others to capacity so that they can meet the needs and provide more culturally linguistically appropriate services. Priority 5 is improving communication and language access for individuals with limited English proficiency and persons with disabilities. We know that we have in this country more than 65 million people who speak a language other than English at home, and nearly 24 million of them, more than 24 million of them, speak English less than very well. But as we also know, for people with disabilities, maybe hearing impaired, visually impaired, navigating the healthcare system to get their care that they need is also a challenge. And so we'll be focusing and working to align with our language access plan and other activities to ensure that we're meeting the needs of these populations so they have improved access to care. And finally, priority 6 is to increase physical accessibility of healthcare facilities. And this is particularly focused on our populations with disabilities. And this was something, as we were doing the listening sessions around the country, that our stakeholders really said to us was an area we needed to focus on. It was not something that was immediately on our radar, but already have begun collaborations within our agency and across the department on how we can measure physical accessibility and incorporate that into other surveys and opportunities to identify the challenges and to provide education as to how we can improve that for our populations. So this is, kind of where we're starting. These 6 buckets, as I said, will be our priority areas for the next 4 years. We will continue to build out very detailed activities within there. We have some already in mind, and then we will be evaluating our progress, looking at our impact on that USA pathway as we talk about the increasing of awareness for healthcare disparities, engaging and activating our stakeholders and target audiences in disparities-focused efforts, and ultimately reducing disparities. We'll be measuring the plan in and of itself, as well as the specific activities for their impact. And we know that in order for us to be successful, it is going to require the support and engagement of many partners, both here within CMS, across the department, and each of you in the work that you're doing. And so we hope that as we move forward, again, we think about the journey of 1,000 miles begins with a single step, but I know that together we can ensure that all Americans have access to quality, affordable health coverage, and disparities in health care have been eliminated. Thank you. So I think we're going to roll right into our next panel, and I was looking for our moderator. There she is. So I'm going to bring up Dr. Madeline Shea, who is the Deputy Director here at the CMS Office of Minority Health. Thank you.
I think I'll invite the panel to come up right now and join me. Is this on? Hello? Okay. So it's a pleasure and a privilege to introduce the speakers for the Taking Action, Next Steps to Reduce Disparities and Improve Quality panel. So finally, we're getting to our action segment of the day. In speaking about action going on right now, as you're going to hear, in major health systems in the country, it's remarkable to me that Dr. Wisdom, Dr. Siegel, and Dr. Sandy will be talking about the work that was first called out in the Heckler report. So I went over and read not the whole report. As you heard, it was quite long. But the exact kinds of things and your problems, your challenges, your solutions resonate today exactly the way they did 30 years ago. I found that striking. So this includes developing and implementing educational campaigns to engage persons with language, culture, or communication barriers, to understanding health risks and resources. It includes examining and adapting the way healthcare is delivered and financed to meet the needs of vulnerable populations. Believe it or not, there's a section of the Heckler report on healthcare delivery and financing. Developing and diffusing new models and programs, and partnering with community and faith groups to improve access to care. So while many of the priority health conditions and strategies that were called out in the Heckler report 30 years ago have not changed, showing that we're still on this journey, we have made some progress in several ways that I'm noticing. That report, they really struggled with understanding. They didn't have the data that we have today. So we've made big progress in our improved ability to use data to create specific performance targets and to benchmark our progress. That's just my own observation from that report. We also have much more information about what works, interventions that work. 30 years ago, we had a big hole in that area. However, one thing that was striking was the Heckler report stated, advances in diabetes and hypertension will no longer need to lead to premature death and disability. We know this has not come to pass. Indeed, we have a lot more work to do. So I want to turn this over now to three equity entrepreneurs, as I'm going to now knight you, who will share their work that is lighting a path forward. Dr. Kimberly Dawn Wisdom, Senior Vice President of Community Health and Health Equity for the Henry Ford Health System. Dr. Bruce Siegel, President and CEO of America's Essential Hospitals. And Dr. Louis Sandy, Senior Vice President for Clinical Advancement in the United Healthcare Group. They have very large, long bios, and I would love for you to take a look at those. They're in your packets. Thank you. So with that, I'll turn it over to Dr. Wisdom.
Great. Thank you very much, Ms. Shea, and I'm very delighted to be here. I really appreciate the invitation from Dr. Kara Jones and the Office of Minority Health, and really want to celebrate with you the CMS's 50-year anniversary as well as the 30-year Heckler report. Very, very impressive. Also, just I feel so appreciative of the Heckler report, particularly my career was beginning to move forward around addressing we called minority health issues 30 plus years ago, and the Heckler report actually gave some lift to that work because it's over the many years has been certainly very heavy lifting. I want to share a bit about, well, for one, I just want to say, I'm also celebrating on another level. I'm finally, as of 7 p.m. last night, when my third child drove off to his job in Grand Rapids, Michigan, I'm considered now, my husband and I, official empty nesters. So all the little little wisdom owls are officially gone, and we are on to a new venture. So that's also an area for us to celebrate personally. But I want to give a perspective related to some of the work that we're doing at Henry Ford Health System, in particular, and how we have been informed by many of the reports and much of the work, of course, that has been occurring at CMS in order to move our work forward. Just quickly, Henry Ford Health System is led by Nancy Schlichting. She's a Baldrige Award. I have no conflicts to disclose. A Baldrige Award-winning CEO. We have she runs a $5 billion company. We have about 23,000 employees. We have a health plan. We have about 1,200 employed physicians, another 2,200 private practice physicians, and about 23,000 employees. So we're a very large integrated model, and but someone mentioned earlier today, leadership matters, and under Nancy Schlichting's leadership, and soon to come Wright Lassiter III, her successor, as well as her Nancy Schlichting's predecessor, Gail Warden, the leadership, I cannot underscore enough the importance of leadership in driving these efforts forward, because they actually gave entree to much of the work that we have been able to do. I also want to say we serve a very, very diverse community. We have a large African American community, very large Latino Hispanic community, as well as the second largest contingent of Arab Americans outside of the Middle East are in Detroit, a large Bengali and Yemen. So very, very diverse community that we serve that continues to challenge us to serve in better and better ways. And just this year, we did receive the American Hospital Association Equity of Care Award, and I know Tomas is here from AHA. We're very delighted to receive that. Also #1 in Diversity, Inc. for healthcare systems, as well as the Healthcare Equity Index Award that addresses the needs of our LGBT community. But it just means that we're moving in the right direction and still have much to do. I want to say that our vision, and I'm going to talk quickly because I know my time is limited, is transforming lives and communities through health and wellness one person at a time. And we went through a major process to come up with this vision, and it was voted on by our employees, but it's something that we really embrace significantly, especially in terms of transforming, because we believe Henry Ford Health System, this is our 100th anniversary, our centennial year, and we have pride ourselves that Henry Ford himself was an innovator. So we often say that innovation is within our DNA. So transforming, we're not talking about making incremental changes. We truly have a spirit of transformation and attempt that in all that we do through our work. What's fortunate and has helped really propel our work forward is that Nancy Schlichting and her vision around performance management and strategic direction actually established as part of our strategic framework a community pillar. So that pillar, along with finance and people, our HR pillar, service, quality, and safety, we call it community pillar is weight-bearing and accountable, which means we have board reportable goals and expectations, and we have to develop a strategy around that. So having that actually drives our efforts up to the very top of the organization, which has been very key in advancing our equity work. Also, what's interesting, I also, as of about a year ago, served not only as leading our equity efforts, but I was appointed as Chief Diversity Officer also. And the beauty of that is the equity and diversity are inextricably linked in many respects, because it takes, certainly diversity embraces the differences and inclusion, but equity ensures that those differences are mitigated. But they work hand in hand in the sense that you have to have a diverse workforce that looks like the community that you're serving if you're truly going to address racial and ethnic health disparities, as well as the other disparities that we heard about earlier today. Back in, it's been a very long journey for us at Henry Ford Health System, but in 2008, 2009, we began to very much structure our efforts around a serious commitment around healthcare equity. I had just served with Governor Granholm as Surgeon General for the state of Michigan for 8 years, and Nancy Schlichting invited me back. I had been serving as an emergency medicine physician and doing research and teaching at the University of Michigan's medical school, and when she recruited me back after serving in that governmental post, I said, Nancy, we have to be very, very serious around equity if I'm going to return, because I really want to move this work forward, and I'm going to have your full support on every aspect. And she wholeheartedly agreed to that. So coming out of the political arena, of course, campaigns were something that resonated with me. So we thought we would conduct a healthcare equity campaign that really would help us align ourselves as an organization, particularly in the city of Detroit, which has had a history of racial challenges over many, many decades ago, and we knew that it was going to be a heavy lift for the organization. Also, I want to underscore the word care, because we know that health occurs where people live, learn, work, play, and pray. However, we didn't want the providers, the physicians, the other healthcare providers to feel that we can't address equity because we're providers. We can't address poverty or social determinants of health. Those are too big for us to address. But when we underscore the word care, we felt this sits right in the center of what you can do. You can assure that our screening rates are much improved. You can ensure that you have a different conversation with an individual that's never had a screening mammogram or a prostate exam before versus someone who gets one all the time. So we felt we are really speaking to the providers, the researchers, as well as the community in terms of we have to all work together to address and eliminate certainly racial and ethnic health disparities, as well as those affected by disabilities and sexual and orientation as well. The goal of the campaign was to increase knowledge and awareness, and also to ensure that people understood the importance of equity enough to begin to integrate it within their practice, not to just know it intellectually, but know it in the delivery of care services, and also to ensure that equity was a key element of clinical quality. We wanted them to definitely link quality and equity, and that's where we got quality and equity are two sides of the same coin. You cannot have one without the other. They are inextricably linked. So we partnered very much. I partnered with the Chief Quality Officer. I said, you need to be my co-partner on this campaign. Nancy Schlichting, our CEO, was the honorary chair, but I said this has to be the two of us together managing this effort. So also, just to give a context, the Healthcare Equity Campaign had 3 phases. 1 was to raise the awareness. 2 was to begin to address training and providing tools for people to help them with cross-cultural patient communication. And thirdly, we wanted to begin, the 3rd phase is the longest phase of all. We wanted them, individuals, to be able to integrate equity into their work ongoing, in an ongoing way and a sustainable way. So we've also aligned it very much with the triple aim, better care, better health at lower cost. So I'm going to walk through what we've done in each of those arenas as well. To start off with the better care or improving the patient experience of care, the collection of race, ethnicity, and primary language data was very key. We're moving more into the realm of religion, sexual orientation, that sort of thing, but this is all self-reported, standardized collection of this data at all of our business units, at every point of service, which are over 100 within our system, and in a way that the CSRs or the registration clerks are trained in how to collect this data based on, of course, Dr. Siegel's wonderful work with HRET and helping us with toolkits to help ask the questions the right way. Also, we launched an effort called We Ask Because We Care. We didn't make that up. We actually, GW, we borrowed it shamelessly from other entities and the Robert Wood Johnson Foundation Aligning Forces for Quality. We borrowed the concept. We developed questions that were very specific to our community. So we do have one related to race and ethnicity, related to our Arab American and Chaldean population. And I just went blank for a moment. But, it's up there. Okay, good. Well, I'm glad I have the slides in front of me. But I do want to mention how leadership, again, is so important. Because in collecting this data at the point of service in a very racially charged community in many respects was not easy. Also, at Henry Ford Health System, we were also, at the time we were beginning to implement this, doing front desk redesign and how to collect, information from people from a financial standpoint. So there was a lot of challenge and a lot of pushing and tugging, like, you want the CSR or the registration clerks to collect one more thing? Really? So that's where we went up to the very top of the organization and were able to have conversations with the CFO and the chief quality officer and say, this needs to happen. And they said, we agree and we will ensure that it happens. And it took that kind of impetus to really drive it and not have it delayed unnecessarily. Is it? I'm not able to see it on the monitor in front of me, so. Well, it looks like somebody else's slides are there. Well, I'm just going to keep, in the interest of time, plugging away. And is that? Yeah, that's yours. Okay. I just can't see it on the monitor. Okay. Improving patient experiences of care. I'll just keep marching through if someone can ensure that my slides that I'm on, speaking on the right slide. Improving patient experiences of care. Also, reviewing the metrics of race, ethnicity, and language data were very important. Also, likelihood to recommend. So when we look at Press Ganey scores, look at those scores. We're beginning to look at those scores stratified by race and ethnicity. Also, sending patient experience surveys in their native language. And also when there's a grievance or there's been a challenge that needs to be addressed, if it's around language issues, it's important to send them a correspondence in the language that they're comfortable with and that they want to receive health information in. Also, rounding experience by all leaders. We call that real rounding, where it includes us as senior leaders. We're expected to round with various teams across the various business units on a regular basis. And with that rounding, we focus our efforts on those with limited English proficiency and the deaf and hard of hearing and address spiritual and cultural and religious issues during that time. Also, in implementing our EPIC, we have our electronic medical record. We have a patient portal called MyChart, which many may have a patient portal in that respect. And we're finding while people that are racially and ethnically different may get the code and actually access MyChart or sign up, enroll in MyChart, they're not accessing it on a regular basis. So again, that digital divide and the ability to access services is limited if individuals are not prepared to make their appointments, receive their prescription refills through that mechanism. Also, a video was developed on how to ask about race, ethnicity, and primary language. In the interest of time, we don't have the time to show that, but it is accessible on this link, and of course the slides will be accessible to all of the people present here and those listening. We have very deliberately developed dashboards where there are metrics that we are reporting to our board. We have an equity dashboard, and from a diversity standpoint, we also have an HR dashboard and a supplier diversity dashboard. And I don't have the ability to talk about our supplier diversity effort today, but we're looking at equity across all of those three domains. You'll see a sample of some of the dashboard measures that we have, whether it's looking at 30-day readmissions, and we're beginning to more and more stratify by race and ethnicity, and whether it's our diabetes bundle, ideal deliveries at least at 39 weeks for our population. So we're having metrics and accountability that are very, very much integrated into the work that we do. Also, we're integrating our equity efforts into our programs and policies. So, for instance, we have many awards that we give to various individuals within the organization or on behalf of the organization. We have equity integrated within that. We have many leadership academies, physician leadership academies, new leadership academies, advanced leadership academies. We ensure that they have a day of training in those monthly sessions where they learn about equity and diversity and how to address it within their particular practices. Also, part of our integration effort, we have most recently instituted a healthcare equity scholar program, where initially it was funded by Association of American Medical Colleges, AAMC, through a $10,000 award. Starting last year, in 2014, we enrolled 20 individuals in that Healthcare Equity Scholars Program. They each had to spend, it was an immersion program, they spent a day a month in learning, they had to develop a project, and then they had to have a time where they could talk about that project. That project is very much integrated in what they do in their particular clinical setting. So this is not something that they're doing separate from their work, it's work that is very much integrated in what they do every day. And also we have an effort to assess how we stand in every single business unit across our organization related to the class standards. So we're taking a deep dive and interviewing and assessing where we are and how we're improving more and more in our class standards. Improving health of populations. As part of our 501c3 tax-exempt status, we are required to conduct a community health needs assessment, a CHINA, and actually develop an improvement plan. And as you can see here, we have outlined, and this is through the data, that we have identified what our priority populations are, and of course you see the underserved, racial and ethnic minorities and infants, as well as health concerns you see there on the slide that we're addressing in that respect, better health, and really taking a population health approach. Also in the city of Detroit, we're responding to the need. I want to say that in Detroit, on average, we have about 200 infants that die before their first birthday. So we have a very, very high infant mortality rate. So we've initiated an effort, of course it came up on our community health needs assessment, an initiative to address that. And we developed a project called Sew Up the Safety Net for Women and Children to link a community health worker with underserved women in 3 neighborhoods to drive down that infant mortality rate. The women in the community didn't like the word sew up the safety net. They're like, what are you sewing up? Is this a quilting club? This is not very clear. So using our community-based sort of participatory approach, we rebranded it with their involvement, and it's now called WIN Network Detroit, Women Inspired Neighborhood Network Detroit, where we are, again, working with community health workers to drive down the infant mortality rate. Of the women that have been involved, we've had 0 infant deaths to date, and these are neighborhoods that typically have 22 to 23 infant deaths per 1,000 live births in those neighborhoods. So we're very, very pleased with the effort, but we know that to drive down health disparities in those neighborhoods, we definitely have to, the community health worker model has been key. I want to say that this community mosaic mural is called Expecting, and actually one of the grants that we received from one of our funders, actually Kellogg Kresge, the Robert Johnson Foundation, have all funded us in this infant mortality reduction effort, and we thought we would draw murals on some of the buildings in each of the 3 neighborhoods that we were working in. Well, we realized that many of the buildings are being deconstructed or demolished, and the mural probably wouldn't last very long. So we decided to take another approach, and that is to develop a mosaic mural. So we work with an organization called SNAP, and each of these, this picture represents 5,000 small pictures or small tiles actually drawings by the community, by board members, by physicians, by members in the community. And the SNAP organization put these together, and it represents where we're going in terms of expecting the best. The 3 houses represent the 3 neighborhoods. The 4 butterflies represent the 4 competing health systems: Henry Ford Health System, Detroit Medical Center, Oakwood Healthcare, and St. John Providence. There's been some acquisition and realignment in Detroit. But those 4 health systems that we compete came together to establish this effort to reduce infant mortality. But I would also say that the larger vision is how can we, being an afternoon speaker, oftentimes the wonderful, great ideas have already been shared, so we thought we'd share something a little more innovative in terms of an approach to take. And part of our vision has been to, if there was in every state and territory in the country, a state-level Surgeon General that could help drive down health disparities and be accountable and be that voice that would help drive down and eliminate, move toward the elimination of racial and ethnic health disparities and disparities related to sexual orientation and disabilities as well. And also address emergency preparedness. So that's just a thought that someone in that position could be accountable and use that bully pulpit to really help drive down and eliminate racial and ethnic and other health disparities. As I get ready to close, I want to mention that how key the community health worker model is, and it's been incorporated in several entities, as you can see here, in our emergency departments, diabetes care teams, but most interestingly, we're getting ready to launch group prenatal visits for pregnant women, all of the same month, gestational month, and they will come together for an hour, 2 hours, over 10 sessions, and share. They'll have their visit. They'll also learn how appropriate breastfeeding practices in order to not only reduce the infant mortality rate, but help these women to be healthier overall and also more self-sufficient as women. So we're really excited to begin to launch that initiative. We're also working very closely with our Michigan Community Health Workers Alliance and the state of Michigan in order to have this community health worker model, this different provider type, actually funded, and ideally through plans or through CMS as a sustainability mechanism for these groups. And in terms of lower costs, part of the triple aim, we're looking at all kinds of ways to address lowering costs so we can redirect funds to individuals or to entities, programs that would help with the elimination of racial and ethnic health disparities. And we've also engaged through our diversity arm, employee resource groups, or ERGs, that actually have been very instrumental in giving us recommendations in terms of how to best serve very diverse communities. As you can see, our Pride group, our LGBT group, African American, Latino, our Generation Y group, our younger millennials, as well as our women. And again, efforts to reduce disparities. And lastly, you've heard of the triple aim, of course, better hair, better health at lower costs, but we've also, when we know within the IOM aims, equity is embedded there, but through stakeholder health, an entity that's led by Gary Gunderson, we wrote up actually the quadruple aim, a 4th aim, and actually to elevate the equity aim very deliberately in order to be most successful. So our journey continues. My last slide. What's right about America is that although we have a mess of problems, we have great capacity, intellect, and resources to do something about them. And that's a quote by our Henry Ford himself. And we truly believe that. And we also believe a quote by Ralph Waldo Emerson. It does not matter where the path may lead. You know, go forward and basically make your own path and leave a trail. And that's what we're doing. We're trying to continue to get lift through various efforts, but also we may have to continue to pave new trails in order to have be most successful in the long term. Thank you very much.
So we're going to hold questions until after all the speakers have spoken. So next we're going to hear from Dr. Siegel.
Great. Thank you very much, Madeline. Appreciate it. I also want to thank Dr. James and also Dr. Gracia for the leadership you've shown at the CMS departmental levels as well. And appreciate your bringing us together today. I'm going to spend a few minutes today talking about making some of this work happen and real from the perspective of a trade association, which is what we are at America's Essential Hospitals. So it's going to be a somewhat different take from what you've heard perhaps before. Give you a little bit of a sense of who we are. We have about 250, now probably closer to 270 member hospitals who are dedicated to caring for the most vulnerable people in our communities. If you look at our membership, it would be places like Henry Ford, who's one of our members. In Chicago would be places including University of Illinois Chicago and Cook and also University of Chicago, among others. And then we have many members who serve very large geographic areas focusing on the most vulnerable, places like St. Luke's in Idaho, WVU system in West Virginia, or University of New Mexico, which serves both Albuquerque and the entire state. Our hospitals tend to have very high level of specialized services like trauma, burn, NICU, disaster response. They're virtually all teaching hospitals. Many are major academic medical centers. And they also distinguish themselves by having very large ambulatory networks that help them to reach out into the entire community. Now, let me talk about the patients who our hospitals serve, of our members. Given who I mentioned who we are, it probably doesn't surprise you that they're very diverse. So when we look at our membership, on average, for our hospitals, most of their patients are going to be Black or Hispanic. For many of our members in places like, say, Elmhurst Hospital in Queens or the LA County system in Los Angeles, they have huge amounts of diversity, with literally dozens of languages being spoken within the walls of their clinics or hospital. Most of their patients are low income. On average, about 40% of our members' patients are Medicaid patients, and in some cases that's as high as 70 or 80%. In some of our hospitals in Texas, fully half don't have coverage. And while it's maybe hard to see here in this diagram, when you look at ethnicity, about 25% of the patients, their ethnicity is unknown in our hospitals. And that leads you to something which I think is really important for the American hospital industry to confront, and which we've tried to help it confront. That is that for most cases, perhaps in contrast to Henry Ford, which is truly a beacon, most hospitals in America don't really know who they're caring for, don't really know the language, the race, or ethnicity of many of their patients, and are far from being able to stratify their outcomes or quality by patient demographics. So we have a long ways to go. Recognizing that, a number of associations came together about 5 years ago under something called the National Call to Action to End Healthcare Disparities. Those include the American College of Healthcare Executives, ourselves, the Association of American Medical Colleges, or AAMC, the American Hospital Association, as well as the Catholic Health Association of America. And these 5 organizations have dedicated themselves to 3 big dots, 3 big goals. First, increasing the collection and use of race, ethnicity, and language data. Second, increasing cultural competency training in our member hospitals. And third, which I think has been the hardest, frankly, increasing diversity in governance and leadership. Those are the 3 things that these associations have pledged to do, and we are now literally going to our members, starting with the board members of our associations, and asking them to sign on to this as a pledge with quantifiable goals. And to not only do these things, but to set targets for themselves and to set where they want to be in, say, 5 years. I'll add to that that in our own association, we're doing this, but have gone beyond that to add gender as well, because we are amazed at the paucity of women in positions of leadership, even in our own hospitals. And we think that's something that also needs to be urgently addressed. I should also mention that with us here today is Tomas Leon from the Institute for Diversity, the energetic new CEO, and his energy and efforts are going to be central to helping to make this vision come to reality. Now, among our members, we also decided to make this work real or implemented in another way. America's Essential Hospitals is a Partnership for Patients contractor. So we have a hospital engagement network, and we're one of the 25 or so or 26 entities that do that. And we have a couple of dozen of our large members involved with this. And Patrick Conway and others spoke about this today. In our own network, we have seen really breathtaking improvements in safety and quality. We've seen thousands of harmful events avoided. Just don't take our word for this. This has been externally evaluated by folks working for CMS independently. And we've seen tens of millions of dollars in cost savings. When we started this work several years ago, when the partnership was first launched, we viewed it as a quality and safety enterprise, but also as perhaps the best opportunity we'll have in a generation to address equity in hospitals. So from the get-go, in our network, we made equity and reducing disparities a central core and tenet of the work of this network. We have our hospitals not only doing this work on quality and safety, we have them collecting patient race, ethnicity, and language data, as well as other demographic data, stratifying their performance and outcomes by this data, finding disparities in some cases, and actually working to address that. We believe that the whole area of equity has to be hardwired into the clinical quality enterprise as the way you're hearing about it today on this panel. Otherwise, it will not be something tangible for the leaders of America's health systems. And we cannot let them off the hook, frankly, in that regard. So while we did this work, and very important work, it had also a very important outcome or product. As we worked with our hospitals, we realized there was no easy, cost-effective way to train the hundreds, in some systems, literally hundreds of patient registration clerks who needed to be trained to talk to patients at registration and collect race, ethnicity, and language data. And this is work that many of us have been involved with for years, but it's still somewhat cumbersome. We thought that one of the good products of this work would be to create a module, create an online training module, which we now have deployed and begun to deploy in some of our hospitals in our membership, which could actually be uploaded into literally every hospital in America's learning management system to allow them to briefly and succinctly train their registration clerks on how to collect this data and literally get certified on it through an online tutorial and self-examination. We're now deploying this. It's, I think, in place now in about 10 hospitals. And we're planning with other partners to begin this deployment nationally to more hospitals across the country. We believe it's a low-cost way to do this work, and we think it will remove the excuses that are often out there when folks say, oh, we'd love to do this, but it takes so much time, and integrating it into our learning system, into our EHR and everything else, we just have other priorities, we'll get to it later. We'd like to take those excuses away, take those barriers down, and we think this will be an important way to do that. So stay tuned for this as we begin to roll it out more across the country, hopefully, in the months ahead. We also think that a lot of this work requires some action on the policy level. And you heard some of this alluded to this morning in some of the opening presentations. We think that the work of equity is absolutely critical, not just for essential hospitals, but for every healthcare provider in America, given the way our nation has changed demographically and where folks live today in our country. We also think there needs to be a policy response to this as well in other ways, and Marshall talked about this. We do believe that for some quality measures, and especially for some of the payment incentive systems that are now being put into place, there needs to be risk adjustment for a patient's socio-demographic status. We believe without that, we risk essentially penalizing those institutions who care for the most at-risk patients. And we send a message to the marketplace that the best way to avoid a quality penalty, and frankly to increase reimbursement, is to frankly avoid certain communities across America. And that would be the worst possible message to send. Now, many of us are working on this. There's been legislation introduced on this in the hospital readmissions program. And I'm hopeful we'll see some movement both legislatively as well as in the National Quality Forum on this in the months ahead. But I think it's a bigger issue than the readmissions program. As we move towards a different set or a different way of forms of payment, ACOs, bundled measures, episode of care. All these things in some way download risk onto new communities, onto different sets of providers, and those models have to take into account the patients who those providers care for and the communities they serve. So I think this is going to become a huge issue in the years ahead as these payment models begin to proliferate. And unless we begin to think about this now proactively, we have a great danger of doing some very unintended harm, but true harm nonetheless, if we don't take account of some of these things. Finally, I thought it was great this morning when I think it was Cara who referenced where we've been as a nation 50 years ago and how, and I got to tell you, many people in my office didn't realize this, some of my younger staff, they didn't realize that what desegregated American hospitals was Medicare. Medicare conditions of participation. In my own lifetime, and I don't think I'm that old, but you may feel differently, we've seen great change. And we've come from a place where we saw signs like that in some of our hospitals, where that nothing could be furthest from our mind today, perhaps in many ways. So while I think we're very frustrated very often, and we're frustrated at the pace of change, and I am frustrated as well, a lot of change has happened in 50 years. And I think we need to celebrate that today as well, because most of that change, the great majority, has been very good. And I think the things that will come out of the Affordable Care Act will be equally as good as we look back 50 years from now. Thank you.
Am I supposed to do something to get my slides up? Okay. There we go. Well, good afternoon. I think, well, first let me say it's really a privilege to be invited to this meeting and to be on this panel. I was thinking about 50 years of Medicare also. How many of you have actually been to the Truman Library out in Missouri, Independence, Missouri? I see a couple of hands. If you ever have a chance, go out there, because at least when I was there, I think it's still there, there's a wonderful exhibit about Medicare that Harry Truman tried to promote national health insurance. As you know, he failed, but he was invited to the signing ceremony. The pens that inked the initiation of Medicare and Medicaid are in that exhibit. It's just a wonderful thing, so I'd encourage you all to go there. And I agree with what Bruce just said. I think there's been a lot of progress, but I think we also have challenges. I think of all the IOM aims, we're making a lot of progress, but I think we actually are making the least amount of progress on equity. And in fact, as probably has been described earlier today, when you drive improvement, there's no guarantee you're going to reduce health disparities. You're just as likely to increase disparities. So I think you have to be extremely mindful about that. These are my disclosures. And I'm going to do three things in my comments. First, I'm going to give a history of what United Health Group has been doing to promote health equity. Second, particularly around our Health Equity Services program, but we have many other initiatives. I don't have time to go into them all. Second, I wanted to share with you really kind of how we approach the issue, from conceptualization to analysis to action. And then third, I want to close with where I think we are now and what we need to do to advance this agenda. You'll hear some common themes. Just by way of background, for those not familiar with United Health Group, we're a diversified health and well-being company based in Minneapolis. Many of you know us as United Healthcare, the national payer. We cover about 45 million Americans across public and private programs, military, veterans, individual, the exchange marketplaces. But we also have Optum, which is a health services company that actually serves about 80 million people through data and analytics, care management programs. And part of Optum, we do direct care delivery for about 2 million people. So we're kind of an integrated, Optum itself is part of an integrated care delivery system of that scale. So when I talk about what we're doing, it encompasses all of it, not just sometimes people just think of us as sort of a payer, which we are, but we're more than that as well. These next couple slides, this is kind of like preaching to the choir. It's really about the rationale for working on health disparities. And I bring this to your attention not because I think you don't know this, but these are the slides that we actually show to employers and to brokers and to consultants to basically get them engaged on this agenda. And I thought you'd be interested in seeing them. The first one we do, this is kind of the background shift, essentially pointing, why should anybody care about disparities, Mr. Employer, Mr. Broker? It's because of the demographic changes in America. And it comes back to the triple aim or the quadruple aim. We have ample evidence of the presence of disparities. We know that we can improve them, and they have an impact on all aspects of care. And it's a critical part of affordability. And we really hone down on the issues that the other speakers have mentioned. When you work on health equity, you're going to typically drive improvements in quality and address sources of variation that can increase costs as well. So that's kind of the business case sort of in a snapshot. Let me turn kind of to the history of our work in health equity. And this is incomplete and telegraphic. I joined United Health. I spent 12 years at the Robert Wood Johnson Foundation and joined United Health Group in 2003. And when I came there was already a great deal of work underway in various places. Multicultural centers of excellence. We joined a collaborative across various health plans to work to improve health equity and reduce disparities. There were multicultural advancement teams. We had work on health literacy. We joined the AMA Commission to end health disparities. But when we took stock, I had been there 3 or 4 years by then, so there's a lot of activity going on, and this may be true in other organizations as well. But it's sort of fragmented. It's kind of in pockets. There are champions around. But your comments I really would agree with. It wasn't sort of pulled together and elevated to a senior level to say this is an important activity. We need to organize it. We need to put it on par with other things that we're doing. And that's really, we created, really 2010 for us was a milestone in that regard, where we essentially said we're going to create an enterprise-wide program called Health Equity Services. And we focused on the term equity. We focused on services. This is going to be a set of activities that were going to make a difference to the people that we serve. And I was appointed a co-chair as a clinical lead. But importantly, and Dr. Wisdom said something similar, the other co-chair was a senior leader from operations who kind of runs the engine of United Healthcare in terms of data and analytics because of the importance of data to driving improvement, into understanding disparities and reducing them. So that was really an important history. We've continued, and I'll share quickly kind of what we did. We started in 2010. It's cross-functional, enterprise-wide, including all of our lines of business, all of our operations, and it's aimed to reduce health disparities and enhance the end-to-end consumer experience, both for individuals and for populations and communities, so multi-level, multi-stakeholder. These are our goals. I don't think I need to read them. I think I would just highlight a couple of them. They include the issues of data. They include the issue of focusing on ourselves, of embracing diversity and promoting health equity as a cultural value in our organization. We are a very data-driven organization, and so we wanted to build and augment our data capabilities to do this as well, and to grow our multicultural capabilities to enhance the member experience for reasons that others have commented on too. Let me give an example of how we approach it. Again, from conceptualization to data to action. This is a slide that we outlined to our leaders around how we were going to drive improvements in quality measures. These are HEDIS indicators across all the lines of business, and issues of race and ethnicity were how we identified them, and we're wanting to address them. So we said, these are the measures we want to focus on. These are the data sources that we were looking at. I want to commend, this is the public sector. I think we take great advantage of the indirect data that we get from Medicare and Medicaid. We are major participants in both Medicare Advantage and in a number of state Medicaid programs. We leverage that data, and we are driving that same approach within our commercial population, where it's self-reported at much lower levels. It's more, direct data collection, but it's at lower levels of comprehensiveness, just like the others have mentioned as well. And this is what we do with the data. This is an illustrative example. These aren't real data for any particular example, but this is how we wanted to array the data. What we wanted to do was say we want to drive improvement in a HEDIS measure, and we want to do it simultaneously by driving improvement in the measure and in reducing disparities. This theme of integration of disparity reduction activities into sort of the mainstream core activities of our enterprise, such as driving improvements in quality. The way we arrayed this, this is an interesting data example I thought I'd share with you, where we essentially put these bubble charts together, stratified by race or ethnicity, on where each race or ethnic group is on a quality measure. And here, going up means the actual performance of the HEDIS indicator is going up. Going left to right is a depiction of the disparity. So what we want is the bubbles to kind of congregate together. That means they are going to be a reduction in disparity, but we all want them to go up because you can have a reduction in disparity, and in this case, this green line is the target for the HEDIS indicator we're seeking. You could have no disparity with everybody being below target. That's not what we want. We want everybody to be moving to decreasing ethnic disparities going that way and improving in HEDIS indicators going that way. And I think similar to what Dr. James had talked about with the CMS quality strategy. Interestingly, when we put this together, I called Marshall's office, the Finding Answers group funded by RWJ, to say, what's the best practice of actually arraying the data in depicting it visually? And they said, and his staff said, well, you might want to think about doing it. The other thing is interesting, when we do this kind of analysis, we don't always find that the white majority population is in the upper right quadrant. Sometimes it's a different group. And so again, really interesting about, that really raises a lot of questions about where people are seeking care and what kind of care patterns are in local communities as well. We then take that kind of analysis and develop an action plan. And these are the kind of typical elements of an action plan. Obviously, the analytics are foundational. Developing specific plans in identified markets for specific measures. It's very concrete. Understand the contours of care, the culture in local communities. In our Medicaid program, we rely heavily on community health workers as a critical component of what we're doing, so that's part of the outreach. We work to promote culturally competent care within our network, and we also have broad cultural competence training, and I'll speak more about that in a minute. But these are some of the typical elements of our action plan that we take our data, identify the opportunity, and drive towards action. The other thing that we do is it's really important, and Bruce said it as well, that as things change, the opportunities we have to leverage what is going on in terms of advances in technology to access whatever resources diverse communities are currently accessing and bring healthcare to the people, to where people are. And so we think there's an important element to leverage technology, to leverage new communication modalities to close gaps in diverse populations. These are just a few examples, and I want to give a couple examples, again, that go beyond just our action plans, which are important elements, but say, can we leverage the resources we have to bring healthcare to the people? One of them, we have a plan, we have a program called Latino Health Solutions. One of the plans within that is called Plan BN. It's very popular. And you can see this, and on the right-hand side, we have a kiosk. This is a kiosk to reduce communication barriers, answer and ask basic information, address issues of low health literacy. And these kiosks can be placed anywhere, in a local community, in a community health center, in a community center, anywhere. And so this has been an extremely popular element of this plan, and it's, again, another example of reducing barriers, in this case, communication barriers. Another one, again, is related to technology. This is a program called Baby Blocks. Baby Blocks is an interactive smartphone free app focusing on pregnant women and those women in the postnatal period. It was developed for Medicaid. And we actually had deployed it in 2011. It's in 14 states, and there's 25,000 women that have taken advantage of this kind of a program. Very popular. It's a smartphone app that allows women to track and stay on track with their prenatal visits and postnatal visits, and they get rewarded. There's incentives in the program for sticking with the program, sticking with their schedule of visits. And the reason I thought this was so interesting is many times here we are at CMS, and CMS is regularly regaled saying, you know, you need to take innovations from the private sector and put them into public programs. Look at this headline. This is something that was developed for the Medicaid population, is now being deployed into the private commercial markets, going the other way because it was so successful. And this is getting picked up. So I thought it'd be interesting to share with CMS, you know, Medicaid can innovate too. So, and you know this, but I thought it's fun to share that. In a related vein, another lowering barriers has to do with, again, dealing with people with complex chronic illness. And this is our house calls program, which is part of our Medicare Advantage population. In-home visits for Medicare Advantage members. This is, again, technology-enabled. Advanced practice nurses go out very often into very diverse communities, do in-home visits, do an assessment, can identify gaps in care, can connect people up to primary care. And in this one, for example, we have actually, working with the RAND Corporation, they published a study in 2012 in Health Affairs, for example, finding for patients with diabetes that the House Calls program had a reduction in hospitalization of 9%, 28% reduction in readmission, and a 7% increase in physician office visits. Just what you'd want to see if you wanted to overcome access barriers. And as Dr. James, I think, said on the previous panel, yeah, just having coverage is not the same as having access. And then having access is not the same as having optimal health outcomes. So House Calls is a really important program for us, part of our Medicare Advantage program. RAND is doing a comprehensive evaluation, as you can see here on the right. The manuscript is under review. Watch that space. I can't say anything more about it. But it is really important in this agenda. I don't know if you can see this that well, but if you look, for example, about the Medicare Advantage population, the Medicare Advantage population generally, I think it's about 30%, a little less than 30% of all Medicare beneficiaries are in Medicare Advantage. But among non-white Medicare enrollees with incomes between 10 and 20,000, 35% of that population is in Medicare Advantage. So one of the things I think sometimes people at the policy level think about Medicare Advantage predominantly from a kind of fiscal point of view or programmatic point of view. It's important to think about Medicare Advantage from a service provision point of view and who's in Medicare Advantage for the reasons that I said. Our priorities, again, we have a well-developed program now, and this has been 5 or 6 years. Our 2016 priorities are to continue to expand it, both qualitatively and quantitatively. We're expanding our cultural competency. We have focused our cultural competency training, like Dr. Wisdom has done as well, and Bruce and Dr. Siegel have mentioned, on the frontline workers that deal with our members. We're expanding that to other groups as well, continuing to advance our data, continuing to advance the appropriate services for diverse populations. And again, it's maturing. We still have a long way to go. But coming back to where I started around, and in closing, this issue of health equity, I really feel is still not as front and center as it needs to be. So for example, this is a screenshot I did. This is the health equity landing page for United Healthcare. It's on the front of the member services, and if you probably can't read it, but it's in the section that says About Us. We thought it was so important to put health equity up there that it's not behind a firewall, you don't need to have an ID card to access it. We thought it was important to really continue to bang the drum around the issue of health equity. And in closing, before I wanted to just close with the other things that I thought CMS ought to think about to help advance this agenda, and not alone. I really do resonate with the idea that this has to be done in collaboration with many other partners and stakeholders. Continue to bang the drum as you are doing around health equity. The second thing is one of the barriers we have, and each one of us has talked about this, is the data barrier. So we have to continue to work to reduce the barrier to collection and analysis of data on race, ethnicity, and language. We really can't make all the progress we need to without that kind of robust data infrastructure. And third, I would urge CMS to continue to have programmatic flexibility and to continue to promote program innovation so that the various kinds of initiatives, such as the ones I've described, can continue to be tested, can be developed, can be deployed within public programs in particular to help advance, to eliminate health disparities, to promote health equity. So with that, thank you very much. Again, it's a privilege to be on this panel.
So people with questions, if you can, you could go to one of the mics in the center of the room. And if you have any mobility barriers and would like someone to come to you, just raise your hand. Thanks. So we'll start in the back.
Hi, thank you very much. I'm Sean Cahill. I'm with the Fenway Institute in Boston. And I was just curious, are there any efforts in your institutions to move toward data collection on sexual orientation and gender identity? Thanks.
There are efforts underway. What we've, I mentioned early in my presentation, the employee resource groups that, and one is called Pride to address our LGBT strategies. And what we're finding as we move forward to identify how we can begin to collect that data, how we can begin to collect religious spirituality data, other preferences, is that of all the employee resource groups, and we use them as a resource to guide our thinking and guide our implementation strategy, is that people aren't necessarily willing to come forward and identify that information, provide that information. So we're identifying ways in order to best address that, how to get that information in a way that will ensure that patients feel comfortable sharing it. And what's very interesting is, and this is public art, one of our leads in our human resources area is a gay man, and he still, when he sees his healthcare provider, he does not come forward and share his orientation. And he's in HR, and he has shared that during our training. A 4-hour training has been developed by the health system, and we're deploying that across the system. So it's an area that we are going to be moving into more aggressively, particularly now that I'm serving in the Chief Diversity Officer role. But we want to handle it in a way where we have guidance, and of course, hearing presentations at meetings such as this is very helpful. But even our list to our LGBT employee resource group members, they don't want that list shared. They're very, very protective. Many of them are very protective around that. So, but on another level, I do want to mention that we're working on policies, even as we're identifying ways. There are sort of several concurrent efforts going on. While we're looking at ways to identify that information and make our not only our patient population feel comfortable in sharing that information, but we have to ensure that we have the capacity and we're equipped to address those issues. But also we're looking at right now room assignments and how do we handle that situation of room assignments if there is a gender factor there that's going to mitigate our ability or create a barrier for us to smoothly move in that area. So that's another effort that for people that do want to identify, we have to be prepared in order to address the room assignment issue, just as an example. So several concurrent efforts, but we have to be guided with a lot of humility, culture humility around that, and do it in a way that we can ensure that we can be most successful and also have the capacity to manage when people do need the appropriate accommodations. We're prepared to do that as a system, not as an individual or as a few people, but as a system. So that's another lift, but we're committed to doing it. Our CEO is a lesbian woman, and she has publicly stated that, and so we very, very, very much embrace the inclusion of all of the diversity within our system, and we're going to move forward very, very carefully with a lot of guidance, but in a way that we can be informed and ensure that we have the best outcomes.
I just wanted to comment on all of your presentations, which were excellent. But I do think that it is really important. I mean, we can't underscore enough the importance of including, or somehow, we're not there yet. We're dealing with demographic data, and that's as basic as it gets. Capturing the kind of spiritual worldview of that culture about health and disease. This is absolutely critical. When I was in clinical practice in New York City, in West Harlem, which is a community of immigrants, you could not get past go unless you understood where that person, family, couple, what they valued, how they perceived and understood health and health care, and when they were diagnosed with a particular condition, what that meant for them. It didn't necessarily mean obtaining a diagnostic study. It could have meant going now to the spiritual healer to manage that with interventions which are completely foreign to the medical community and will not be discussed unless we, the healthcare professionals, are open and accept it with respect. And this is under the radar, but it is very dense, very present, and I think that certainly it allowed me as a clinician, as an internist, to better understand this whole notion of compliance. Mm-hmm. Was it really non-compliance? Mm-hmm. Was it something else? Was it a decision that was actively made to manage their own disease, their own health, in a different way? Then when they got done, they would return and say, "Thank you very much, doctor. I'm ready for what you want to talk about and how you want to manage it." So I'm sure that you've experienced that, all of you, and
yes,
if you could comment on that.
Yes, great comment. I think what's really resonates with me with what you said is there's one aspect of collecting the data and having the fields in Epic and having all the technical pieces and knowing what you want to collect. It's another thing to have the capacity within the organization to respond to what you've collected. Because once you've collected it, you have to respond. I mean, you can't have people divulge all of this information and then not have the ability to understand it and respond to it. So I just think of an example, and we have used at times this LEARN model. You can Google it, and it's everything from really listening and then actually negotiating what should be done. So you hear, does someone want a spiritual healer? Does someone want to keep their medicine bag on during surgery? Some people that are Native American. And of course, from a surgeon standpoint or from a healthcare standpoint, you want a sterile environment, but some people want to keep their medicine bag. That's just as important in maintaining their blood pressure, having that medicine bag somewhere on their person as it is, managing their care. So it would be problematic to ask these questions and a person says, yes, I want my medicine bag during my operation, and then it not, during all the steps that have to take place to get to that surgery, to not have that medicine bag taken away at the last moment when everything else has been done right. So the whole notion of asking is one thing, collecting it, having it in a database, we know what we have, we know the demographics are very clear, but then we have to have organizational capacity. And that's what we're working on, as I said, concurrently, because we want to be there when the patient says, okay, now you know, now what are you going to do? And if we drop the ball there, I think we've done a great disservice to the patient.
Yeah, I wholeheartedly agree. And again, you have to, in order to meet the needs of both individuals and populations, you have to look at it from their point of view, not from your own point of view. I didn't mention this in my remarks, but we embarked on a cultural initiative across our whole enterprise as well, with 5 cultural values: innovation, performance, integrity, relationships, and compassion. And the one that gets the most queries from our own people, our own employees, is compassion. Well, what does compassion mean? And it has many different meanings, but one of them is to walk a mile in someone else's shoes and feel what it's like to be that person, in ways that get outside yourself, your own worldview, your own organizational view. And I think of all of them, my personal view is that's sort of a killer app in terms of trying to transform systems to be more responsive to people that we serve, because that's what business that we're in.
See, we have another question in the back.
Hi, Kellen Baker from the Center for American Progress, and I want to thank you all for your insightful comments and presentations today. I did want to return briefly to the first question regarding the collection of sexual orientation and gender identity data, and this is a little bit of a plug, if you will excuse me. CAP and Fenway actually worked together on an RWJ-supported project called Do Ask, Do Tell, which is about the collection of sexual orientation and gender identity data in clinical settings. So we do have a website. You can look us up at doaskdotell.org. And we have also done some research into this question that you brought up quite rightly about concerns among LGBT patients regarding the disclosure of sexual orientation and gender identity and the issues of discrimination and poor care that can still accompany those kinds of disclosures. I wanted to ask specifically to Dr. Sandy whether you could speak from the perspective of United Health Group. We're seeing a lot of barriers to care for transgender people, particularly related to gender transition, starting to fall away. In particular, I mentioned earlier Medicare removing its exclusion. And I'm wondering if you could talk at all about any initiatives at United Health Group to remove these kinds of barriers to coverage for transgender people, and then talking, especially from your clinical perspective, about what the organization may be doing to facilitate better access to care for transgender individuals.
Yeah, thank you for that question. And it really is an important issue that has been in the news lately as well. Our focus has really been looking at our medical policies and our clinical programs to be sure that all the people that we serve, including the LGBTQ community, have the services they need and they don't have untoward barriers in that regard. Regarding transgender in particular, one of the issues, you asked me sort of my clinical perspective. I think one of the issues generally in the transgender world is really around kind of the usual ways that people look at trying to measure quality and identify, for example, the kind of care providers that can do gender related surgery. What are the quality measures? How do you know who is qualified to do that kind of procedure? And what kind of appropriateness criteria ought to be developed to understand who ought to be eligible for such a procedure, for such procedures? The issue there is that the typical way that we would look at this is we would look at the medical evidence, we would look for authoritative sources, so this is an open invitation if there are sources like that, but this field is a little bit thin, frankly, in kind of evidence about, for example, what criteria one ought to use to credential a center or a facility or a physician to be involved in this kind of care. So I think that's one of the kind of, it's not a payer-specific barrier, but it's an issue in the field. not to mention there are kind of ongoing differences of views around timing, sequencing, age, and things like that, which are really unsettled issues, I think, in the field. So these are, again, not unique to this area. All of medicine has areas of different points of view, but I think if there are more authoritative data sources that can be leveraged, those are important for all stakeholders to help advance the quality of care for this population as well.
Thank you, and definitely agree about the importance of quality measures related to transgender health, and I would just point interested parties to the World Professional Association for Transgender Health, the Standards of Care version 7, regarding the provision of care for transgender individuals. So thank you for your comments, your responses.
Yeah, I wanted to thank you for letting us know about the Do Ask, Do Tell campaign. I was not aware of that, and I hope, and I hope there's people in this room who hear this, that as the partnership for patients continues, which I think it probably will, it has access to about 4,000 American hospitals who are engaged in it. It would be great to get that work in front of them in a systematic way, because I think that's really where a lot of the equity quality interface is happening. We've had several member hospitals ask us about doing this, and we haven't felt like we said yes, but we don't know enough about how to advise you on how to ask these questions, what to do when your staff asks, why are we asking these questions, the whole panoply of issues. So I'm looking forward to seeing that work and hope we can broadcast it more widely. This is the right time for it.
Thank you.
Desiree?
Hello, my name is Desiree De La Torre, and I'm with the Children's National Health System in Washington, D.C. Thank you so much for bringing your work to action and to highlight with the rest of us. I wanted to hear from you, and I know that many of you have the experience of working with beyond the health clinical setting, so working beyond the hospital walls and with the community and with other organizations, and how CMS might take that as an opportunity to work with other government and public and business sectors to improve health equity and health improvement, of course.
At Henry Ford Health System, as we launched our healthcare equity campaign, we agreed that we would not only work with providers, we'd work with our researchers, and we would also work with our community as well. So we have several initiatives. We're pretty deep in the neighborhoods, in part because we have community health workers, and we make great attempts to hear on a regular basis the voice of the community and be guided by the community. Even the example that I gave when we thought we came up with a great name for our infant mortality reduction efforts, so up the safety net for women and children, and all of the stakeholders that were around the table got it and said, oh, what a great name. And then we went to take it to the community, which we should have done during our process. We realized that. But we then renamed it. So we're steadily getting their input. But what we've done, several things. We've done focus groups for all of the major racial and ethnic groups to understand what the needs are, what they're interested in around equity. We transcribed all of those. We work with our Michigan Roundtable for Diversity and Inclusion organization in the city of Detroit. Then what was key was we went back around after we did all these focus groups and then shared that information with every group as part of our integrity process, that we're not just going to hear information from you, but we're also going to share back what we heard and share what we're doing. So they're very much guiding our efforts, related to this work, whether it's infant mortality reduction. We have a very robust effort related to nutrition education, physical activity, youth leadership development. We very much work to address everything in our community health needs assessment and more. But we take equity, diversity to that level where we're steadily in the neighborhoods, in the community, understanding what the needs are, and trying to be that trusted provider that people will feel comfortable coming to us to share what's going on, to share what we could do better. And so that's why even that mosaic that I shared with you, where many of the people in the community contributed to that, we also listened, we heard from them, they participated, and then it resulted in this beautiful mosaic. We have 3 of those mosaics. They live in 3 neighborhoods in the city of Detroit, and can be moved if the building is demolished. They can be moved, but it's symbolic of we steadily want to hear your voice. We want you to have a place at the table. Even on our efforts related to infant mortality, we have a task force, but we also have major evaluation meetings, that sort of thing. We have a community health worker present, and we'll probably eventually have a community member present. So we very, very much embrace the community and steadily hear from them. I think that's one way that we do it, and take into account what they say. So let me just give one other quick example. For instance, we understand that we have health fairs and that sort of thing for these women to get them enrolled in various programs. Well, we realized that we had a booth for diabetes and one for the various health conditions. Well, what the community needed, they needed their ID. Many individuals needed someone to sit at a booth and make sure they had an ID. Without an ID, many of us have our government-issued ID, no problem. We carry it with us all the time. We have access to a lot of things. People don't have an ID, and I'm not talking about people born in this country. They don't have an official ID. So we have booths that help them get IDs. We have booths that help them understand how to work with Children's Protective Services, various agencies, how to show that you're taking good care of your children. I mean, so we have all kinds of ways to make sure we listen, and then we make sure that we respond to the community in a very robust way. So that's our efforts related to equity. And like I said, 0 infant deaths, preventable infant deaths. And it's because they feel a part of our team and a part of the network, and we're there for them.
So I'll maybe use Baltimore as a lens into this. So we are right outside of Baltimore, which is a city with grievous health inequities. And many of you are probably familiar with the recent events with Freddie Gray's death, and today the court settlement was announced. So if you look into what happened there, you'll find many root causes. But one of the things you'll find as a dynamic is lead poisoning for him and others who were involved in the case. And because of the inability or unwillingness or whatever of Baltimore to deal with this issue, at least in part, it's led to a cascade of other issues. So to me, when you think about health inequities, you're thinking about issues around housing. You're thinking issues that touch the justice system, economic development, because certainly Baltimore has certainly been held back by these health equities economically and in terms of development. And you even look at financial regulators, because actually one of the things that came out in the recent interesting expose is that there are financial firms who prey upon lead-poisoned families to cash in their settlements for a lump sum payment. And that's probably perpetuating economic and probably health disparities as well. So I think the question isn't necessarily, there are many partners, and I think right now I don't think enough partners realize how much of a stake they have in helping us to solve some of these issues, and how much of a role they have as well.
I think you're going to hear common themes. When I think about working across a diverse group of stakeholders to advance this agenda, again, one thing I didn't mention in my formal remarks is that our United Health Foundation, which is supported by corporate contributions, recently went through a strategic planning process and came up with 2 goals along the lines of your question. And the 2 goals, and we've actually decided to focus grant making at a bigger scale in 2 areas. The first one is diverse workforce, for all the reasons that has been a theme, that we need to have a workforce more diverse, more representative of the people that are seeking care and need care. So that's one set of initiatives. But the other one is healthier communities. And when you say you're going to have a data-driven approach to improve the health at the community level, again, I'm sure I'm preaching to the choir, that takes you far beyond medical care. That takes you into the school systems. That takes you into neighborhoods. That takes you into family support. That takes you into prisons. That takes you into the policing culture and system. In my hometown now in Minneapolis, there's quite an innovative model called Hennepin Health, that some of you may have, which is kind of a broad medical and community social service initiative across the entire community, focusing on the most vulnerable populations of people with complex medical, social, behavioral, mental health, financial issues. And then those are the kinds of initiatives I think that we're going to see more of, and And now is the time to try and work together to do that. That's why we as a foundation thought it would be important to have that as a major aim, because it takes us there and takes us in places. And I'm seeing, and a related one, coming back to United Healthcare as a payer, when I look at the most advanced ACOs that we work with, what are they doing? They're doing the same thing. They're saying, wow, there's a population that has this constellation of medical and social things and family issues, and we need to work collaboratively with partners beyond our medical care skill set in order to make progress in this area. So I'm very optimistic about that. It's a lot of work. It's a lot of internal cultural change for medically oriented organizations, but that's where you have to go.
Thank you. See, we have another question in the back.
Yeah. Hi, this is Jordan Luke from Cigna Healthcare. I'm very interested in your work around colleague resource groups.
Can you get a little closer to the mic?
Yes, I'm an active participant in the colleague resource groups at Cigna, and I'm very interested in your work there. One of the challenges that we face is when we have groups that are double or triple minorities, they face even more unique challenges. So what are some tactics that you've used to break down silos and create more effective partnerships between those colleague resource groups?
Well, we are still exploring that. We bring each of the leaders, each of the employee resource groups have a leadership team and a board, and they have an organizational structure. We bring and this has just been in probably the last 6 months as I've assumed the new role and identifying ways that we can continue to advance our diversity and inclusion agenda and our equity agenda as well. We bring the leadership of each of the groups together to share what each of them are doing and how they can best support each other. So whether it's their structure, whether it's how they can work together on initiatives such as signing people up for My Chart, but in terms of how when you have multiple groups that sort of this cumulative effect or multiple effect of being from different groups, we have not in a systematic way begun to address that. That's a great point, and I'm sure we will get to it. But there's no doubt that understanding across those groups how we can improve care that's delivered as well as improve outcomes for even our employer group. Thank you.
This is a question, I guess, for all of you, but have any of you started using retail clinics as well as sort of in a coordinated fashion for Medicaid patients or for to expand networks, but also to work as a triage to primary care docs when someone doesn't have them, and with safety net hospitals at the same time, to be in essence a triage from the emergency room as well.
Well, we think and coming back to the theme that just having coverage doesn't necessarily mean that you have access, that I think as we are now in the post-ACA sort of startup phase and now getting into several years of experience, we need to have multiple and diverse access points in order to meet the needs of the populations. And we think retail clinics are part of that. We have had retail clinics in our network for a number of years. And we think that that's an important element, but not the only element. We think that patient-centered medical homes are important. We think that community health workers that can understand the barriers in care in local neighborhoods are important, which is why we've built them into our Medicaid programs as well. And we think that telehealth and telemedicine are another one as well. Many of them I think we need all of those solutions, and it will vary market by market because of the local delivery system configuration about what is the right configuration. And again, this is where, when I talked about our disparity action plans, they're at the local level. They're in particular communities with particular quality indicators, because I don't think you can peanut butter spread and say we're going to just do X and it's going to solve the problem. I think you have to let it be driven by the data and the local neighborhood context.
So we have a few members who are involved with it from the perspective of staffing them, but then also a number of our hospitals are fairly large players in the Medicaid managed care arena and have, for them, relatively large plans in their states and often include these clinics in some of their networks. Couldn't tell you what their perspective is on it, but they're certainly in there.
Do we have any more questions? Okay, well, join me in thanking this panel again for this great presentation.
Our next panel is getting seated. This will be the final panel of the day, and we will have closing remarks from Kara James, so please hang in there with us to the end. I'll turn it over now to Maria Haar, also a member of the Office of Minority Health.
Good afternoon, everyone. Thank you so much for joining us this afternoon. This is our last panel of the day, so we're very excited to have our regional partners here with us. My name is Maria Haar. I am the Director of the Program Alignment and Partner Engagement Group in the CMS Office of Minority Health. And it is my pleasure to introduce to you our next panel, which will address the CMS regional perspective to learn more about what are some of the challenges and opportunities that we see related to health disparities across the country. We had great information this morning to understand the history of the Heckler report and how much we have done around health equity, and also some of the current work that our office and the rest of our federal partners are doing. And now we would like to kind of also see what our regional partners are doing, and also how we can move forward together to really make a difference. So with that, I would like to introduce our distinguished speakers and partners. We have Ms. Nilsa Gutierrez. She's currently serves as a Chief Medical Officer for the Center for Medicare and Medicaid Services in Region 2, which includes New York State, New Jersey, Puerto Rico, and U.S. Virgin Islands. She also serves in a clinical advisory capacity for some of the CMS programs, and also as part of the senior leadership team. Our second speaker is also Mr. Daryl Means. He is the Deputy Regional Administrator at the Centers for Medicare and Medicaid Services in Seattle, Washington. He is a key leadership official responsible for supporting CMS outreach activities and directs the operational activities for the regional office. So with that, I would like to turn it over to Nilsa. Thank you.
Hi, I'm Dr. Gutierrez. Pleasure to be here, and I really want to thank Kara James and the OMH staff for inviting us to discuss what regional offices do and the challenges that we face when we are working with the communities that we serve and the states we serve, and raising all of those challenges through CMS up to senior leadership. So when Daryl and I decided to, we were discussing what we would share with you today, we thought that it was important for you to appreciate a couple of things. Number one, there are 10 regional offices, and each regional office has a senior leadership team, including a chief medical officer, and that's the role that I serve in Region 2. And as you see there on the map, you see that Region 2 is New York State, New Jersey, Puerto Rico, and the U.S. Virgin Islands, which are listed on top. And of course, it also includes 8 Native American tribes. And throughout the country, our job, our role is to understand what is occurring in those states, in those communities all the time. And our role is to really appreciate and bring to the organization, bring to CMS, what the impact of program policy is, good or bad, positive or negative, and then what actions we can take to address them. We thought, as we discussed how we would spend this time with you, we thought that we would describe 2 realities that occur both for Region 2 and Region 10. And for Region 2, it's the struggles that we have appreciating what the impact is, the unintended negative effects of Medicare and Medicaid policies because they differ in the territories. And I'll spend my time talking about that. And Darryl will focus on Alaska, where issues of geographic isolation and poverty are huge, and what it is that we can and cannot do with respect to addressing health disparities. So to start with Region 2, in our region, we're responsible for Puerto Rico and the U.S. Virgin Islands. In Region 9, that regional office is responsible for Guam, American Samoa, and the Commonwealth of the Northern Mariana Islands. So I'm not going to discuss the Pacific Island issues. I'm going to remain on the Caribbean because that is the area that I'm most familiar with and the issues there. But I want to bring these to your attention. These are Medicare and Medicaid program policy differences in the territories. And it affects all the territories with the exception of Northern Mariana Islands that does have supplemental security income. But just to start at the top, Medicaid funding is capped in the territories, which means that there is an annual limit. So it is not open-ended as it is in states, and that has a direct effect on what services can be provided to Medicaid beneficiaries, both mandatory and optional, as well as the extent to which these funding caps really has a direct impact on building or not building the healthcare infrastructure. The low-income subsidy is part of the Part D, Medicare Part D program, which provides subsidies to individuals of low income for prescription medications. There is no low-income subsidy available for residents in the territories who are U.S. citizens. Medicaid, the federal match for CHIP, for the Child Health Insurance Program, does not consider their capacity to pay for services, and I'll talk about that a bit more. Again, there's no supplemental security income except for the Northern Mariana Islands. And the Medicare savings programs, which really helps individuals who are Medicare beneficiaries who are above the Medicaid eligibility income level, it allows for Medicaid to contribute to supporting these individuals with co-payments, deductibles, and care services. So this is a map that actually gives you a sense of geography and distance between the Virgin Islands, which is St. Croix, and St. Thomas and St. John, and then Puerto Rico. And you'll see that Puerto Rico is much, much larger. There are about 3.7 million people in Puerto Rico, residents, and in the U.S. Virgin Islands, it's about 110,000. The reason why I bring this map to your attention is because the way that the funding rules, the funding formula is established by Congress, it calls for Puerto Rico receiving 90% of federal funds because it is comprised of 90% of territorial population. So it means that every time, all the time, the Pacific Islands and the U.S. Virgin Islands is always at a disadvantage in terms of funding opportunities simply because of size. And so we're not even considering need here. It's just size. The U.S. Virgin Islands, as you see here, distances, this is 40 miles. St. Thomas is separated by deep ocean from St. Croix. And it means that the Virgin Islands has to establish a full spectrum of healthcare services on each island. It's got to create something. It's either duplicating it or creating it in triplicate. That costs money. It requires a healthcare workforce, which they do not have. And then, of course, it's the expense of importing equipment and supplies because it is considered an international destination. And that creates tremendous barriers. In the island of St. Croix, there is one hospital. St. Thomas, one hospital. And if you go through the spectrum, all the healthcare sectors, home care, hospice, nursing home, et cetera, you generally have one program, one facility, one service provider. If for whatever reason that service provider does not meet the conditions of participation of the Medicare program, we have an obligation, right? If we are expecting everyone to provide services at a certain standard of care and quality, we are obligated to terminate that facility or that program. But every time that we are faced with that difficulty and that challenge, we are essentially creating a gap, a service gap. And so our struggle in the regional office is when we find ourselves, when we do our work in survey and certification and to ensure that these programs are meeting the conditions of participation, we are often faced with the access issue versus the quality issue. How much, how far, and that is a constant struggle. And to make a point, for example, the major industry in St. Croix was a refinery company, an oil refinery company. It closed several years ago. When it closed, the entire economy of St. Croix nearly crashed. One industry, one time. All of the employees of the plant are now without jobs. All of the businesses, small businesses that supported that refinery, gone. The schools, the private schools that the employees were able to support because they generally had higher incomes, closed. And now you had people who now are join the ranks of the uninsured. You have a Medicaid program that is capped, which means that beyond a certain dollar amount, there are no more dollars to provide services for individuals who might be eligible for Medicaid, but simply the program simply runs out of money. And so this was a near crisis situation in St. Croix. And I bring that to your attention because one action or one situation, one occurrence can essentially dismantle the services there. This is a listing of healthcare disparities, but the point is that when you have a program where, in the Medicaid program in particular, where the annual funding is $16 million, which when you compare it with states is, constitutes a few cents. It really, we can really appreciate and understand how many of these issues of obesity, high blood pressure, number of individuals who have end-stage kidney disease because of poor management and screening of high blood pressure and diabetes. It is a tragic situation. But I want to bring to your attention also certain factors that are unique to Puerto Rico and helpful for you to appreciate what these differences in Medicare and Medicaid policies mean, because it comes closest to our comparing a territory to a state. Puerto Rico has 3.7 million people, and on the next slide you'll see that the Commonwealth population is greater than 26 states and Washington, D.C. It has 2.4 million Medicare, Medicaid, and CHIP beneficiaries, which is 65% of the population, which speaks to a large extent, the level of poverty on the island. And by the way, the Medicaid poverty level, the Commonwealth poverty level, is $500 per month, or $6,000 annual income. Okay, so we're talking about, this is about 40% of what the federal poverty level is in states. It has more Medicare beneficiaries than 25 states in DC, and it has more beneficiaries of Medicaid and CHIP than 40 states. The dual eligible population is 44%, and 3/4 of Medicare beneficiaries are enrolled in Medicare Advantage. And it's because it is affordable for the reasons that I'll describe in a few moments. And almost all of the dually eligible are enrolled in a Medicare Advantage plan. This is important because when we look at the Medicare and Medicaid policy differences, the impact is quite measurable. So, for example, when we age into Medicare, we are automatically enrolled, and we are notified by Social Security. And that gets the ball rolling. In Puerto Rico, Part B enrollment is not automatic. You must actively enroll. If you actively enroll and it is late, you are penalized, and you are penalized throughout the life of the program. And this is a formidable problem. There are thousands of individuals who have to pay a penalty, and we know for a fact that they drop out of the program because they're unable to pay the Part B premium. The prospective payment systems for hospitals, this is important because Puerto Rico is the only territory that has adopted PPS. But all of the hospitals, the 59 acute care hospitals on the island, and Puerto Rico does have a robust healthcare system, and it's very similar to that of states. None of the hospitals are, or the acute care hospitals aren't required to report quality measures. They don't receive Medicare EHR incentive payments. They do not receive Medicaid disproportionate share payments. The Medicare DISH payments are far lower because there's no supplemental security income, which is part of the formula for calculating Medicare DISH. And the net effect of all of these policy differences enacted by Congress and signed by presidents has the net effect of creating a very, very weak and vulnerable system on the island. Right now, the Affordable Care Act was able to provide the territories, all of the territories, with over $6 billion of additional funding beyond the Medicaid cap. But we have two problems. What if you can't pay the match? And apart from the fact that the Medicaid program is capped, the match is 55 cents. So the federal government pays 55 cents to every dollar. And unfortunately, if we were to follow the same rules as states, we would be able to, or Puerto Rico would be able to receive an FMAP of about 83 cents to the dollar. So those two issues really limits the Medicaid program, and because the Affordable Care Act did provide funding for significant funding, $6.3 billion, 90% of those dollars went to Puerto Rico, which now, for the first time, it was able to provide Medicaid benefits that are mandatory, as well as add some optional services for the first time. But the fiscal crisis in Puerto Rico has now created where it cannot pay its $72 billion in debt. It's in debt and now cannot pay that debt, does not allow it to provide the match for those Medicaid dollars provided under the Affordable Care Act. My point here, it's a vicious cycle. And we in the regional office try very hard to work with the Commonwealth government, with the U.S. Virgin Islands, as it faces many of these challenges. And our role is to really convey to senior leadership in CMS the unintended negative effects of these policy differences that really has created a situation that is near crisis in both Puerto Rico and the U.S. Virgin Islands. And I'll stop there, and Darryl will cover his region and the challenges he faces in Alaska. Oh, this one's the slide. Oh, the slide thing. Okay.
Thank you, Nilsa. First of all, I want to say that the slides that I have, a few of them come from our Chief Medical Officer presentation that she did. And I wanted to give credit to Dr. Nancy Fisher for some of those. She's our equivalent of Nilsa out in Seattle. Also, when you look at the data, depending on where you look for data, the data changes. And I think you all know the difficulties in getting accurate data. So the data that I show you here is just reflective of, from a comparison standpoint. I'll give you some numbers. And last but not least, I do want to thank Dr. Kara James for inviting us here to be part of this. So before we get started, how many people have been out to the Pacific Northwest? Raise your hand, please. Oh, a lot of people have been out there. How many have not been out there? Okay, well, thank you for indulging there. It lets me know that you're still awake, and I don't end up like that guy in the car commercial riding around talking to himself. All right, all right, all right. Again, this is a map of our regional breakout here. You can see Region 10 off to the left. Region 10 consists of Seattle, or Washington State, Oregon, Idaho, and the state of Alaska, which is kind of tucked up there, but we all know that in between Washington and Washington and Alaska is a foreign country. So it by itself makes it very difficult. Today I'm going to speak on some of the health disparities in rural areas. And again, this is another thing. If you look at data, you'll get all sorts of information on what people consider rural. Even in the federal government, it can go from 50,000 inhabitants all the way down to 2,500 or 2,000 inhabitants. One thing I did want to point out in Seattle, in our region, Seattle and Portland are the only main metropolitan areas. There are other larger cities or large cities in Idaho and things like that, but the majority of the populations, if you will, are in those two areas. When people think of rural, they often think of Idaho or Iowa or Montana, and these are rural states as well. But let me take a little minute here. I want to paint a broad brush picture for you while we're on this slide. If you look at Baltimore and its metropolitan area, there's about 6.7 million people who are in Baltimore, not the city, but all around. If you look at New York City, just the city alone, there's about 8.5 million people in New York City. When you look at all of the states of the Northwest, there's about 13.5 million people in all of the states in Region 10. So these slides may be out of order, but I'll have to get back to that one. But let's just take a look about, at Alaska and focus on that. If you lay it on top of the U.S., this is the landmass that Alaska covers. And its population is just a little bit shy of what you find in the city of Baltimore. So from a landmass perspective, some could say that all of the states in the Northwest comprise about 20 to 30% of all of the U.S. territory if you put it together. And part of the reason is because of the amount of space that Alaska takes up. Many studies for the years have documented that people in rural areas suffer more from being sick. A lot of them are older, and a lot of them have trouble accessing care. And that's no different than what we see out in the Seattle region. This is why we think it's very, very important that we continue our strategy of getting out to these rural areas and talking with people and bringing the CMS messaging out to these areas. But there are some that think that because of space and because of the small amount of people in these areas, that it's not a good return on the investment. But we've talked about this in this forum all day, that all lives matter, right? So whether they be 2,000 or 3,000 people in a small community, it's important that we communicate with them and help those Americans achieve a healthier life as well. Traveling in these areas creates a lot of difficulty for us. And the reason is most of these areas that are rural don't have national airports. They definitely don't have international airports. So technically the only way to get to most of these areas is to drive. In Alaska, it's even more difficult because depending on the time of year, you may have a road, you may not have a road because of the ice road. And we've all seen the ice road trucker shows. And one of the things that show brings out is that there's a limited time that they have to get their products up and down the road, because as the road falls, you know what happens. They fall in. So the only other way is to take little puddle jumpers or little small commuter jets in and out of these areas, which don't run all of the time as well. So it's important that when we can get to these areas, that we get to these areas and we bring the CMS message to them and the HHS message. One thing that I think is clear here is that there's no A train out in the Pacific Northwest that you can catch on a continuum to get you from point A to point B to point C to point D. It's nice that here in Baltimore they have a good public transportation. We're working on that in the Seattle area, but at the same time Portland has something, but there's no connects that get you from our regional office to all of the points that we need to touch. Therefore, again, we have to drive. We already talked about some of this. This slide needs to be updated, so I certainly apologize about that. But one of the things you'll see up in Alaska is that there's 220 some odd recognized villages. And when I say village, I mean village. These aren't towns like you're used to. These are pretty much villages in need of a lot of things. And another issue that we have is among the Native Americans or the Alaskan natives that are out there, there's a lot of different languages that they speak. So you can't just say, like you say, okay, Latino in a sense, and you can go and you speak Spanish. That doesn't apply out here. You know, you will have to know the dialect that they have and be able to communicate with them in that dialect. And that's where a lot of the sisters and others play a big part in helping us. Nielsen already covered a lot of the factors that affect people, from poverty and environmental factors and things like that, the determinants. But One of the things that she had on there was economic, and I would like to bring to your attention that when you get out to these rural areas, there's no industry, and I think you talked about that in Puerto Rico. And the result of that is that a lot of people out there are dependent on support to make it from day to day, and they're living at a minimum as far as their lifestyles. The distance is a big problem. A lot of times there's a lack of sewer systems out there and water treatment facilities out there. In the case of Alaska, when the permafrost falls, that's a problem because nothing can stay on top of the land. You have to move things around or else it falls through the permafrost. And then there's Medicare limitations as far as getting care. And something that's not on here, I think it speaks about it, but oftentimes it's not doctors out there because a lot of the doctors don't find a return on their investment to be out there in these areas, and they kind of pull up stakes and move closer to the infrastructure or the I-5 corridor or somewhere else because they have to make a living too. So sometimes it's very difficult for people in these communities to get assistance that they need to stay healthy. This talks about the census data, and there was a slide that was earlier that reflected this. I think if I can go back to the slide, see if it was up front here. This shows the breakdown by ethnicity in the Seattle regional, right, in the Seattle regional purview, Region 10. As you can see here, one of our major ethnic groups is the American Indian, Alaska Native up in Alaska. We have a lot of Latino and Asian American. And so we do a lot of outreach around that group. With respect to the African American and some of the burgeoning communities that are coming up like Hindi and Somali and things like that, we do struggle in those communities because we haven't been able to define where those communities are. Another problem that we're having in Seattle is the fact that high tech has set into the Seattle proper, and that has raised the rent on a lot of things. So people are starting to migrate out of Seattle into the valley, especially a lot of the African Americans. So it makes it very difficult for us to understand sometimes the needs of this community as they migrate because we can't identify how many people are where sometimes. And they don't have community groups internal to those areas that they're living or moving to. So we do work with some other agencies such as Catholic Community Services and those folks who are hearing things, and we try to keep our ear to the ground as far as what's going on so that we can deliver our messages out there as well. How do we overcome some of these challenges? And that's kind of the crux of what I want to talk about here today. Knowing that we can't just get on a train and go somewhere, we have to be creative, if you will. One of the things that we do is an annual rural road trip where we kind of put as many people as we can in a car, and we map it out to these rural places that we want to go. Oftentimes we'll talk to providers, sometimes we'll talk to support agencies, and sometimes we'll talk with beneficiaries as well. This year road trip was provider focused, and we went on a road trip through rural Oregon. There was a group of 4 people who drove over 750 miles, stopped at 8 rural locations, held 16 events, all of this in 4 days. So you can see the challenges there. Obviously, if you're driving 750 miles in 4 days and trying to do all of this, it's tough on the staff. But at the same time, it's valuable because we get information from these providers on what's going on. Pretty much what we talked about was MACRA, the Medicare Access and CHIP Reauthorization Act, and how these changes will affect them. And we got a lot of feedback from them that said, yes, it's tough for us to make some of these changes because of the resources that we don't have. So it's important that we understand that. We've done this in libraries. We've gone around and we've done it as they say, we've done the same thing and invited beneficiaries in, and all of this is important. Let's talk about the marketplace real quick. Our only FFM or federally facilitated marketplace is Alaska, and that has presented some challenges. But although that has been the focus over the last 3 years, we've also had to come up with some creative ways of going into Alaska because of cost and the time that it takes to get up there. Therefore, we do have a marketplace lead. That person goes up there every year right before the open enrollment. She's planning on going up there this month at the end of the month. She's been working with a lot of the navigators and certified application counselors up there, and she does attend their meetings remotely and give them an update of what's going on from a CMS perspective, all the information that they need to know. Now, we don't try to circumvent the things that are in place for them to get assistance, the processes and procedures, but at the same time, we try to pay a little bit more attention to them and listen to what's going on. Another thing that we do is that we work with our other colleagues at the other optives like HRSA and ACF and things like that, and if they're going to Alaska, we try to arm them with information about the marketplace and things like coverage to care, and we get them to take that information up there on our behalf. And that has been pretty effective to where we keep the communication going, we keep the messaging going. I think that was the,
Yeah, I think these slides are off
yeah, they're off a little bit.
quite a bit.
Just want to make sure, okay. So I just wanted to make sure I covered all of the slides. The last thing that we do is that we try to engage with the faith-based organizations and try to go out to the churches, to the mosque, and that's another way, because that's a trusted entity within the community. We can get a feel of what's going on. One of the things that we've started this year is, and this was associated with WIAPI. Everyone know what WIAPI is, the White House Initiative on Asian and Pacific Islander. They were doing roundtables, and I thought to myself, that would be a good idea. Why don't we do listening sessions? So one of the things that we've tried to do this year that has been very valuable is go back out to our partners and say, what's going on? How is the message from CMS being received? And what are some of the barriers that you're seeing in your groups that we can improve upon, or that we can help you improve upon? Because some of these barriers are ethnic barriers, and we talked about that here, I think, with the last speaker, and I think Nielsa brought that up. But some of these it could be anything like a superstition and stops them from going to get care. One of the reasons we started this is that there's an Asian lady in our office who has some friends, and her husband had health care for the first time. Not her husband, but her friend's husband had health care for the first time last year, and he never used it. And at the end of the year, he died of a heart attack, and no one understood why he didn't go get care. So that raised the question to us about how do we ensure our messages are heard and that they're received properly and people are utilizing care. So hopefully you're aware of some of the challenges we face from a financial, spatial, access to care, ethnic standpoint due to the rural nature of our region. Geographics can tend to present major challenges to us and in the education and outreach that we do within the community. So with that, I do thank you for your attention at the end of the day, and I turn this back over to Maria.
Great. Thank you so much to both of you for sharing your insightful experience and also discussing all of the challenges and opportunities. I don't think we have any time for questions at this time. I don't know if there are any urgent questions out there, but we're running out of time. And I would like to turn it over to Dr. James for our closing remarks. Thank you.
So I will make this brief, as I know it's first day of school for some people, rush hour for others. But I just want to start by saying thank you to every single one of you and to our panelists today and our speakers. I think that we've heard a lot of really rich information, and I know we've been taking copious notes and instructions on what to do and where to go. And I hope that this will be, as we say, that first step, and we'll continue in our journey along the way. I also have to say thank you to my team who helped to put this together. And so I see a couple people, so I'm actually going to embarrass you and have you all stand up. You have met many of them throughout the course of the day as they've greeted you. You've met Pamela, who's been leading our conference planning, along with Pat, who's hiding in the background somewhere. But I just want to thank our team for helping to put this day together and the work that they've done. I think it's been a really good day and lots of learning, and that is really a credit to each and every one of them. So thank you for your efforts. I think one of the things I just wanted to also think about is in the closing out the day and looking at where we are and where we've come from, I think it is worth, despite all of the challenges that still lie ahead of us, to take a moment, as Dr. Sandy and Dr. Siegel said, to just reflect on the progress we have made. And we have made a lot of progress, but it just is continuing on in the journey that we have. And I think of what we still need to do, and I reflect back on some of the comments we heard earlier this morning from Dr. McGinnis, and he shared his story of Mirza's mother. And I think, again, just really laid out some very clear steps of what we need to do to achieve health equity in understanding our community, understanding our challenges, understanding our strengths, and moving towards our action as we go forward. I think we have heard in every single speaker a continued cadence for better data and more data, data on some of the populations we haven't spent as much time looking at and developing strong measures, and so that's something that we continue to need. But we also heard, in particularly our panel, about our health providers and plans and health systems who are taking action, about the important need for leadership and guidance in moving these activities forward and making sure that they're not happening in that part of the organization or that part of the community, but they really are integrated and central into the activities and the work that's going forward at a top level and part of the regular following that we have. And we're very pleased here at CMS that health equity and reducing disparities, particularly in healthcare quality, is a CMS priority, and we are tracking that as we move forward and report up to our leadership on how we're doing as we're addressing quality overall and working in collaboration, as I mentioned earlier, with our Center for Clinical Standards and Quality. We also heard, and I think our last panel here with our region, and we could have had all 10 of the regions give the perspective, where you live matters. And where you live matters for so many reasons in our healthcare system, as we think about whether it's a federally facilitated marketplace or a state-based marketplace, whether the state has expanded Medicaid or not, whether the state has an organization like the Henry Ford Health System focusing on health equity, or if it's an organization that this is not a priority for. If we're serving and meeting the needs and partnering and collaborating with our communities to address the needs of the populations that we serve, where you live matters. And it continues to matter and continues to be a focus in the work that we do here. Finally, we unveiled some of our first steps in what we're trying to do to address health equity in Medicare, in quality there, but also shared a lot of the other activities that we have underway. It's just a snapshot of some of the things that we're doing and will continue to do. And as I said, as we mentioned this earlier, we know that in order for us to achieve health equity, we need each and every single one of you working with us on that path to health equity. And so I hope that as we close, you'll continue to partner with us, to let us know what you're doing, what works in your community, and to share that so we can continue to build that learning and collaboration and share that across the country so that ultimately when we meet again in 50 years, we can say that we have achieved health equity. Thank you so much for your time, and be safe getting home.
Yes, please complete your evaluations before you leave today. There's a box on the table, and there are members of our team that will take them from you. So we really would appreciate your evaluations. Have a great evening.